Hi, welcome everyone, and thank you for joining me today. My name is Jennifer Tillerson, and I'm an ASCP certified MLT working as a generalist in my local hospital. I'm currently enrolled as a distance learning student at Winston-Salem State University in clinical laboratory science, working towards my bachelor's degree. I'd like to present to you today the idea of a study that would reevaluate the current reference ranges of the D-dimer test and how this test is utilized to diagnose and treat thrombolytic conditions in the hospital. Currently, only a specific cutoff value is established that states that if the D-dimer level is less than this cutoff, a thrombolytic condition is unlikely. In my facility, this particular cutoff value is less than 230 nanograms per milliliter. So essentially, if the dimer level is 230 nanograms per ml or less, the dimer is considered to be negative. A positive D-dimer test is indicated if the value is above 230 nanograms per ml. This result, along with a clinical pretest probability assessment guide, which was probably done by the physician in the doctor's office or the emergency room, this guides the doctor to decide whether or not radiologic studies, such as a CT or ultrasound, are warranted. Then the CT and ultrasound results further indicate whether or not a thrombolytic condition is present. I believe that the dimer reference range could be further studied through additional testing and possibly recategorized according to age, gender, and maybe even race in order to better determine what a normal D-dimer level is and distinguish it from an abnormal one, which could potentially alleviate the need for unnecessary radiographic studies while still properly diagnosing the patient's hemostatic condition. Now, when the test originated in the 1970s, it was used mainly to screen for the indication of disseminated intravascular coagulation. But as testing methods were developed that increased its sensitivity and specificity, it has become an integral part of the puzzle to diagnose and treat patients with acute thrombosis. Currently, the dimer test is primarily used to aid in the diagnosis and treatment of venous thromboembolism, pulmonary embolism, or cerebrovascular accidents. Now, low levels of dimer are found in normal, healthy individuals, but increases can be associated with a variety of conditions, such as pregnancy, inflammation, surgery, trauma, cancer, infection, or aging. Therefore, elevated levels don't always suggest the presence of a thrombosis. One study I researched, performed by Lincolns et al., found that dimer levels were 2.5 times greater in individuals over 70 years of age when compared to patients less than 50 years old. In another study, it was discovered that only 5% of patients over the age of 80 have a negative D-dimer test result. These high test results decrease the dimer specificity as a diagnostic tool in the evaluation of thrombosis, which is interpreted as a positive result, leading to unnecessary radiologic testing to rule out conditions that literally don't exist. The result is high because it's not unusual for it to be increased with age. After researching this topic and past studies performed, it is my recommendation that further investigation should be done to evaluate the possibility that age-specific, gender-specific, and maybe even race-specific reference ranges for D-dimers could be established. Many studies have been done to suggest age-related reference ranges, but the field is lacking when you look to include differences in genders and races. My study would involve the compilation of 1,000 dimer test results obtained for men and women 18 years of age or older, representing various racial groups. Selected participants will include normal, healthy individuals as well as those that present with symptoms of thrombolytic conditions in order to differentiate what will be considered a normal test result from an elevated one, so that the test can maintain its ability to aid in the diagnosis of thromboembolic conditions. Exclusion criteria for my study will include individuals who are pregnant, active infections, cancer, trauma, recent surgery, or diagnosed arthritis, because we already know that these conditions naturally increase the dimer levels. The samples will be appropriately collecting using your sodium citrate vacutainers and tested on the ACL Top 350 using the classic HemoSeal D-dimer assay. This test requires a 9-to-1 dilution of the blood, so any tubes that are overfilled or underfilled will be discarded and eliminated. And since this test is also sensitive to hemolysis, any hemolyzed samples will be discarded. Results will be categorized according to race, gender, and age. Race categories will include white, black, Hispanic, and Asian. The gender categories will be defined as male and female. Age categories will include 18 to 30 years, 31 to 50 years, 51 to 65 years, and then those that are greater than 65 years old. The results will be examined collectively, where each specimen will be categorized according to age, race, and gender. The data will be compiled and stored using a statistical package of the Social Sciences Software Application System at the completion of 1,000 test results. And then they will be evaluated to determine if applicable reference ranges in fact do apply. Upon completion of my study, I expect to find that my results will confirm my theory that D-dimer results can be categorized and applied to gender, specific ages, genders, and races, while maintaining its ability to effectively rule out and diagnose existing thrombolytic conditions. A dimer level of 500 nanograms per ml in a 65-year-old female will not have the same significance as if found in an 18-year-old female. It could very well be considered normal in an older woman, while it would indicate a possible thrombosis in a younger woman. An older woman with a dimer level of 1,000 nanograms per ml might be more indicative of a thrombosis and would justify further evaluation. I would also expect to see a difference in the gender category, with women running slightly higher than men of the same age. As far as variations in the results among different races, well, I would also expect to see normal values presented there as well, but it's uncertain as to how they would be displayed. It would be interesting to see. Standardization of the reference ranges for the D-dimer test would allow this test result to become a more useful diagnostic tool and would play a more effective role in the diagnosis and treatment of patients displaying symptoms of thrombosis. Are there any questions or comments? If not, well, I thank you for your time and thank you for joining me today.